could watch the presentation. But most importantly, after we're all done, I'm going to take the presentations and break them up into like 5 to 6 individual videos and post them for folks that couldn't make it. They can still review the presentations and watch the content. Okay. We have plenty of food, so please feel free to get seconds, thirds, and fourths throughout the morning here. And then the folks will be back to clean that up, and we're having lunch brought in at noon as well. Okay. There is a tentative agenda on the back table. If you haven't grabbed one, feel free to grab one. Also, probably most importantly for all of you all that want Con Ed, make sure that you signed in and put your certification number down on the sheet so that we can type it into the Magic EMS registry. And you guys will all get 6 hours of Con Ed for today. Okay. So I want to thank you all for coming. This is the first conference that we've had for preceptors here in a while. The goal is to make this an annual event. So around the same time every year, we'll do a conference for our preceptors. When we put the agenda together, the idea was to do a mix of student engagement, preceptor type content, as well as just good general medical information. So as you see, there's a difficult airway lecture. Dr. Lazar is coming over from UPMC to talk about ECMO. And Dr. Slimmer is coming up from Geisinger to give a really good talk on the ABCs of trauma care. He came in and did this lecture for our students a couple of weeks ago. And it's really, really good, really well done. It's the same trauma lecture that he gives to his new residents on how to manage and approach trauma patients in the trauma bay. Okay. We also have some program/preceptor specific content today. So I'm going to give a brief overview of kind of where we're at as a program, as well as talk about the importance of preceptors and the process from an accreditation/program director perspective. Professor Breon's going to give a talk on student engagement. And for those of you who were lucky enough to have him as an instructor, Brady has a very unique way of engaging students in the classroom. So there's not very many people that are better at giving a talk on student engagement. And then Dr. Fraley is going to give us a talk on preceptors/field process from the medical director perspective. So all of us know that as paramedic students and as providers, when we're out playing paramedic and taking care of patients, we're really using his license to do that. So it's really important to kind of understand from the medical director's perspective what appropriate expectations are for students and how we should be kind of training our students to function as the next generation of pre-hospital providers. Okay. If you have any questions at all about the program, any of the topics that I talk about, obviously, during my presentation, just feel free to go ahead and shout them out. Okay. Okay, so the first thing we're going to start with is a quick program update. So everybody that's ever gone to paramedic school knows about terminal objectives, right? You kind of get this talk when you first come in the program of these things that you have to do to graduate. And then as you go through the program and get towards graduation, we get a little more in depth and detailed about the things that you're missing and the stuff that you need to do in order to get out of here and be certified as a paramedic. These have become a much taller order than they are in the past. I can tell you that the number of patients, so the minimum number of patients that you have to contact in school hasn't really changed that much. What has changed is the specific numbers of specific patient types that you have to see. So we'll have plenty of students that had cardiac arrests, but not enough chest pains. So then we have to send them back to the ER towards graduation to get chest pain patients. And we went from having like 5 to 6 different types of patients, different presentations that a student needs to see to graduate to like over a dozen. And this is where the importance of adopting FSDAP as a program has come into play, is that FSDAP is really designed from an accreditation perspective to monitor and track student data and student performance, and then run reports to make sure everybody can graduate. And it's all derived from the students' data entry. So the students are able to track and trend what they're doing and make sure that, you know, for example, if they have a patient complaining of abdominal pain and chest pain, and they have all of their chest pain patients, but they need an abdominal pain, they themselves know to document that chief complaint as abdominal pain from the checkbox, so they get credit for an abdominal pain patient, okay? So these are the current terminal objectives. So every paramedic student that comes into the program, we do an orientation the week before they actually start in program, and we kind of present to them what they need to do, what they need to accomplish in order to graduate. The idea being every student should not be surprised that they needed to actually see trauma patients in order to get out of here, okay? They have to see 40 trauma patients. That's not a big deal. You'll see more than 40 patients that fell and slipped and bumped their head and are classified as a trauma, okay? The problem is 6 of those have to be peds and 6 of those have to be geriatrics. So now we're getting a little deeper in that 12 of those, at least 12 of those 40 have to be either under 18 or over 65. So the ages become important. Okay, they have to see at least 30 pediatric patients with 2 in each age category of infant, toddler, school age, all our developmental ages, all the way up to adolescence. We're very fortunate as a program in that we have Geisinger Medical Center right down the road. And our students are still able to spend a day in the NICU and a day in the pediatric ICU. So as long as the census is okay in both of those units, our students get most of their pediatric contacts, especially specific ages in those categories. It also highlights the importance of sending students to the Little League World Series. Besides the fact that the Little League World Series is a great way for students to kind of experience EMS operations at a large-scale event. There's a lot of kids there, and for some strange reason, sliding down a hill on a piece of cardboard is a fun activity. Right? So there's lots and lots of toddlers and school-age kids and adolescents that, you know, hurt their ankles, hurt their wrists, need a Band-Aid, and the students document all of those patient contacts in FISDAP as patient contacts. So by the middle of fall, a lot of our students that were very proactive at Little League World Series and really documented well can have half of their patient contacts done. Other programs in the country that don't have access to pediatric facilities and don't have access to things like Little League World Series, they end up sending their students to places like daycares for the day just to do basic patient assessments because there's no other way they're going to see all these toddler and school-age kids. So we're very fortunate where we are and the relationships that the program has built over the past 40 years in that our students are able to actually see these patients as live patient contacts with actual complaints and not just going into a daycare and saying, hey, let's read you a story and do a patient assessment so I can document that I talked to and did an assessment on a school-age kid, okay? You have to see 100 medical patients as a paramedic student in order to graduate. 12 of those have to be pediatric, 12 of those have to be geriatric. You can have more than that, for example. So as a student, in theory, you could have 88 geriatric patients and 12 pediatric patients. That's perfectly okay. But the minimum in each of those age categories need to be 12. So in order to complete the paramedic program, you also have to successfully pass a summative exam. The accreditors in 2015-ish kind of clarified this language in that it has to be a summative and a psychomotor, and that the summative exam has to be done at some point during or at the end of internship. What was happening was paramedic programs were doing their summative exams before internship, and the accreditors came back and said, learning's not complete yet, that's too early. So we actually have a defined time in which these things have to be done. So what we do as a program is for the psychomotor exam, every student has to successfully pass in the lab every registry station using the same registry evaluation sheets that we utilize in national registry testing. We utilize that as a program as our summative psychomotor exam, and it also prepares the students to take the national registry practical exam. We also utilize the FISDAP summative exam. We utilize the FISDAP exam for a very important reason. FISDAP has done a lot of research into their summative exam, and you see how the exam is broken down into different categories. These are the same general categories that registry breaks their written exam down into, okay? If students achieve a minimum of these scores on the summative exam, they pass registry on their first attempt 95% of the time. So we know with general confidence that once a student takes the FISDAP exam, remediates, and gets a minimum of these scores, we're confident they're going to pass registry, okay? The other important piece to it is every time a student gets a question wrong, that category goes on to a learning prescription for that specific student. So every student has a slightly different learning prescription after they take the FISDAP written, and we can tell them, you have 5-volume paramedic textbook and hundreds of notes and all these presentations from Professor Breon over the past year, but here's the 20 things that you got wrong on the FISDAP exam. So you're going to take registry in a month. Instead of trying to relearn all of paramedic school to prepare for registry, focus on these 20 topics because these are your weak points. The students can take this more than once. They can take this actually up to 3 times. And we do this about a month before registry. The idea being that we're giving the students a full month to have an idea of their likelihood of passing registry, as well as what they need to do to prepare. Our goal as a program is always 100% first pass success, and we're hoping that this specific exam is going to help increase our chances of getting there. So other graduation minimums. So I talked about breaking these down. We used to have like 6 different patient types you had to see. You see now it's much more specific. Every student needs to see 2 stroke patients, 6 acute coronary syndrome patients, 2 patients with cardiac dysrhythmias, 2 respiratory distress and failures, 2 diabetics, 2 septic patients, 2 shock. The interesting thing is, as a program, we used to previously count all of the tox and overdose patients as psychiatric patients. Because if you look at addiction, it is a psychiatric disorder. We're no longer allowed to do that. The students have to see 2 toxicology/overdose patients, which are separate from the 6 psychiatric patient contacts. One of the other changes we've made is, instead of going down to Geisinger for our psych rotations, we're now going to Divine. We're like the only students at Divine Psych. So the students are there for a day and they're all getting like 8 to 10 different psych patients sitting in on group. It's kind of interesting in that some of the psychiatric patients kind of are asking Mindy and the students not to leave or to come back the next day because they enjoy having somebody else there to talk to. Once again, there's other programs that don't quite have access to those psych facilities. They're kind of complaining a little bit about the 6 psychiatric patients. We're fortunate and we have a place to go, and our students can see at least 6 psychiatric patients during their rotation there. They have to see 2 cardiac arrests. This is an important thing for us, and we were going to move towards this anyway. Professor Breon had noticed that we did have students from the program. It doesn't happen often, but we've had students who have graduated and just for some stroke of luck had never actually participated in or run an out-of-hospital cardiac arrest. So they were graduated, credentialed, and they go on a call as a single provider, and their very first code is they're by themselves. So a student, for example, could have everything else done but not the cardiac arrest, and they end up getting an incomplete and have to continue through internship until they get their codes. Because the goal here is entry-level competence in every domain, right? 20 ultra-mental status patients, 20 abdominal pain patients, 30 chest pain patients, 6 OB patients. So these are not just necessarily patients that are delivering, but any patient who is pregnant would count as one of the 6 OB patients. They have to see 2 live births. One of those have to be a vaginal birth. The other can be a cesarean section. 10 syncope patients and 10 vertigo/dizziness patients. For skills, they have to successfully start a minimum of 30 IVs. We don't currently have a minimum percentage success rate. That is something that I'm going to be meeting with the medical director here over the next month to talk about for the next year's class, about during internship setting a minimum IV success rate for graduation. I know at a lot of the services, EVAN, for example, one of the ways in which the entire department gets raises is, as a department, they have a minimum IV percentage success rate, right? So they want to really make sure that when they're hiring students, that they're able to start IV successfully. So if a student successfully starts 10 IVs during internship but misses 30, that's a problem. So we're going to probably establish some type of minimum, like 70 or 80% IV success rate. And if a student doesn't meet that, we're going to probably end up sending them to the ER to help remediate that skill a little bit. They have to give 30 medication administrations. For those of you that remember having to go to the OR a lot to get 10 tubes, we now require 12. We also require, in addition to the 12 live intubations, 12 supraglottic airway placements, which are generally done in the OR via placing LMAs. The students, before they start doing all of this, they start going to the OR just to ventilate and place oral airways, and they have to do 20 live ventilations. So if you're doing the math, every paramedic student that graduates from our program will have successfully managed at least 44 airways. Generally, it's about 50. So we're really pushing excellence in airway management and teaching students all of the skills in the toolbox and the steps to successfully managing an airway, so that most importantly, if they miss the tube, they know what to go to next. They're comfortable with supraglottic placements. They're comfortable with the fact of, I can't get anything else, but I can ventilate with an oral airway. That's good enough. Let's get to the hospital. Okay. We also require 50 successful ALS team leads and internship. We set last year a minimum of 5 of those 50 being class 1s. So we've had students in the past that have graduated with their 50, but every high priority patient, STEMI alerts, stroke alerts, really complicated medical and trauma patients, it wasn't so good, right? So we're tracking their ability to not only successfully manage ALS patients, but to really also manage those super sick patients that are time sensitive and need appropriate life-saving care. Maybe. There we go. So for those of you that are preceptors that have gone to the program previously, you'll remember you completed a module or you completed a semester, you successfully passed the course, and you then got released to do the skills associated with that course. We as a program were mandated to adopt the paramedic psychomotor competency portfolio, which I'm going to give you a snippet of in a second, is a very intense, in-depth skills/scenario template that the students have to complete. Part of that is completing peer evaluated skills and then completing instructor verified skills. Once all of the students in the class have successfully demonstrated mastery of those skills, they then get released to do them in the clinical setting with generally with Mindy in the ER, and they then get released to do them in the field. So our goal is always, as early as possible, to get the students moving from the lab to doing these things on live patients. What that means as preceptors is you're seeing rolling skills releases throughout the semester where students are getting released to do IVs, getting released to do medication administrations, et cetera. It also means that students may be released in the field to do things individually. So for example, we'll say Dr. Fraley has permitted every student to start IVs in the ER setting. And once they get a minimum of 5 IV starts in the ER, they can start them in the field. Well, those students are all going to hit that magic number of 5 at different points in the semester. So we'll then release them to start IVs in the field. Okay. This thing should be updated in Play-Doh. If you ever have a question, you can call or email me or Mrs. Carr, and we'll help get you straightened out. But we never want to hold a class back because 1 or 2 students have not hit mastery yet. So we're really sensitive to the fact that once a student has demonstrated they can safely and effectively do a skill, we want to get them to start incorporating that into their pre-hospital care as soon as possible. The way the portfolio works is lab, clinical, field, and that's the same way our skills releases work, with some minor exceptions like electrical therapy is typically done just blanket. Most of our major skills, intubation, supraglottic placements, IVs, medication administration, start in the lab, get released to the clinical setting, and then once they've demonstrated success in the clinical setting, roll out into the field setting. These are all released via medical command authorization. So I, in writing, request release from Dr. Fraley. If he agrees, he signs it. That means that for cause, a student can have their medical command revoked, just like a paramedic can. So if we have a student who, this is outside the typical student learning perspective, really demonstrates unsafe practice and we're concerned about their ability to perform all skills or a specific skill in the pre-hospital setting, through the medical director, we can revoke their medical command authorization and send them back to the lab for remediation, then back to clinical for remediation, and then re-release back into the field. Okay, that is a big place where the preceptors come in. We need you guys to be telling us if a student is demonstrating really dangerous technique, so that we can try to take action to help remediate that. What we don't want to have happen is for a student to be doing something in a horribly unsafe manner and it not to get noticed until after they graduate. It's like, hey, this guy's a medic and he stuck himself with an IV catheter. Like, this is a problem. Okay. This is kind of a small box, but this is what the students' lab skills look like. So as you can see, they're very explicit. They're very exact. Moving left to right across the spreadsheet here, they start with doing things a minimum number of times in the lab setting. This is just basically your standard checklist. I have thread the head for intubation. I have the IV arm, and I demonstrate to the checklist that I can safely and effectively do this skill. The next box over that blue line are formative scenarios. So for intubation, for example, as a student, I safely and I effectively demonstrate that I can do the intubation skill with my peers. An instructor verifies that through an instructor skill check. I then move into small isolated scenario testing in which the only goal is to intubation. But we know that patients don't come with checklists, right? So we're very early in the process, moving away from checklist medicine and towards you're presented with this patient who's in hypercapnic respiratory failure. What do you do? And have them move through the airway management concept. For some of the skills, they then move into isolated skill competency, where they're doing these largely in the ER, and all they're doing for a patient is that skill. And then finally, they're doing that in either a large-scale scenario or in the clinical or field setting in an actual dynamic patient care setting. So these are monitored very closely. The students monitor these as well. And it's a very dynamic, explicit way of teaching competency. Here's page 2. I want you to try to pay attention to the numbers here. The students, by the time they graduate, will at a minimum have performed 60 skills via checklists. They will then perform 64 formative scenarios. They will do 74 individual clinical competencies, and they will perform skills or procedures in a dynamic patient care scenario 143 times. So these are additive. So if you move all the way left to right across the screen, just in the lab/clinical setting, each student is performing hundreds of different individual skills and procedures that we're tracking and trending, okay? The reality is we as a program may have been doing this, if not more than years. We just weren't tracking it this closely. So now we're getting a firm grasp and we're tracking this. The benefit for the student is they have access to this portfolio at graduation. So if as a paramedic student, you want to go somewhere besides in this local area and they say, hey, you're a brand new medic, what did you do in school? They can show that not only did they meet the minimums, but they went to a program that exceeds the minimums across the country, and they've seen hundreds of patients and they've performed hundreds of skills to help that new agency kind of feel comfortable that they would be a good quality provider to hire. This is the scenario template. So the students will perform at least 10 team leads in the lab scenario, the lab setting, and they'll participate as team members at least 10 times. So our students in reality are doing 30 to 40 simulations over the course to a year, if not more. Actually, they're probably doing hundreds with the team member. But as a team leader, they're doing 30 to 40 team leads. But as a minimum, they're doing 10, including pediatrics, adults, and geriatrics. The hope is when you see all these numbers and you see these different, very explicit, very dynamic ways of tracking and trending student competency, the goal is that you're starting to see students when they hit internship more prepared than ever before to function as a competent entry-level paramedic, okay? There's always going to be exceptions, obviously, but the goal is that when they're stepping from that team member to that team leader role, they've done these skills and procedures enough and they've had enough simulations in lab that they're more comfortable functioning in that team leader role. And what we've seen over the past year in evaluations from preceptors in general, that does seem to be true. There are some exceptions, but what we really see happen are the cardiac arrests, for example, where we very rarely have students that have no ability to run a code. By the time the students hit internship, they're doing pretty well because we've done it dozens of times in lab and they kind of have that script and that process down. So moving on from kind of a program somewhat of a program update, talking specifically about preceptors, internship, and accreditation. This next couple of slides may be kind of boring. I apologize for that. However, our accreditors require me to talk to you about this. So we talk about some accreditation standards and goals. So the goal of our program, is to prepare competent entry-level paramedics in the cognitive, psychomotor, and affective learning domains. The question always becomes, what is entry level? Okay, that's one of the things that really the only person that can answer is Dr. Fraley. As our medical director, he establishes as the system and as the program what entry level competence is. I can tell you from working in different places across the country, our standard of entry level is what most places expect with a year or two of experience in the field. Okay, we as a program, through our medical director, are able to set standards above what our accreditors consider minimum entry-level competence, but we have to basically say why we did that, and most importantly for the students, it has to be documented upon entry, which we do. We require a much higher bar for our students than most other programs do. That's not going to change. If anything, the program probably gets a little more difficult every year. The tests get a little harder, the lab expectations get a little more difficult, the lab scenarios get a little more complicated and dynamic, which is appropriate because, as we all know, for folks that have been doing this for a while, our patients are getting sicker, right? Folks that used to just drop dead at 60 are now living to 70, 80, and 90, and their disease processes are developing and worsening more. So we're seeing sicker patients live for longer. So we as hospital clinicians need to be better able to take care of these folks. Our program goals must be published. We have all of these published in our advisory committee notes as well as in our program manual. So every prospective student that is a pre-paramedic major or pre-any major can click into our program manual and they can see exactly what we expect of our students before graduation. So probably the most important person in the entire program is our medical director. Every pre-hospital system that I've worked in and every program that I've been involved in, the main difference that decides whether that program is or that system is successful or unsuccessful is the degree of involvement from the medical director. So what the medical director is responsible for is medical oversight of the entire program. Dr. Fraley reviews and approves every single thing that we teach. He reviews every exam that we administer. We take his feedback and alter exams or add questions based upon his feedback. He has stamped the minimum numbers of expectations from those portfolio slides that I showed you earlier. That piece is a little easier because Dr. Fraley is also intimately involved in our accreditors. So he knows about these changes before I even hear about them. And he can kind of help explain the rationale behind them for all of us. He reviews and approves all of the testing instruments that we use, including skill sheets. He reviews the progress of each student throughout the program. He ensures the competence of each graduate in the cognitive, psychomotor, and affective domains. And he also, this is a big piece, is he ensures educational interaction of physicians with students. So for a lot of our students, Dr. Fraley is kind of that liaison between paramedic and physician. And one of our goals as a program is to get students comfortable talking to physicians. We want the students to understand that medical command and medical direction is there to help you. And we want somebody like Dr. Fraley to be here for the students to build a relationship with. So if they get in trouble on a patient, they're not afraid to call medical command and ask for help because they understand that physicians are really there to help them. So the field internship, which is the part that the senior students are in right now, the field internship, the internship locations must provide the opportunity for the students to participate as a team leader in a variety of advanced life support emergency medical situations. So the most important thing for our internship sites is that our internship sites and our preceptors are going to allow the students to actually, in a hands-on manner, function as a paramedic and function as a team leader. A lot of clinical sites don't want students doing invasive skills unless they're physicians or physician's assistant students. A lot of them are designed with clinical agreements that are written to be observational. So we end up having to do addendums to ensure they understand that our students are going to be doing invasive skills, right? And imagine you're the CEO of Geisinger Medical Center or UPMC Susquehanna, and you are really concerned about risk management and patient assurance and quality improvement. And some guy from Penn College comes over and says, hey, we have a student that learned how to start IVs 3 days ago and want him to stab patients in your ER, right? The initial reaction is going to be hell no. So we have to foster these relationships with these clinical sites and get them to understand the importance of training high quality paramedics. And we're very lucky in that all of our clinical sites are more than willing to allow us to do that. We have to establish minimum team leads, and they have to be accomplished by each student. This is a long definition, but basically the student, to be a successful team lead, needs to run the call. The student, in order for it to be an effective team lead, does not have to do everything, okay? But they have to do something. So we see two extremes of students when they first start their internship. They want to do everything and not delegate anything, or they do that like internal medicine approach where they kind of stand in the corner with their hands folded and want to tell everybody else how to take care of the patients while they look at the monitor. One of the things that we need to do as preceptors is kind of guide them in that you do the most important critical action and delegate things to other people and kind of get them to be in more of the cooperative leader facilitating the call. So in order for it to be a team lead, the students have to do a comprehensive assessment, establish a field impression, determine the patient acuity, formulate a treatment plan, direct the treatment, and and participate in the treatment of the patient to a medical facility. Transfer to a higher level of medical authority or termination of care in the field. Okay, so the students, in order for this to be a successful team lead, the students can't delegate the assessment to somebody else. The students can't delegate the history taking to somebody else, right? Because what happens then? A student that knows they're not very good at doing assessments delegates the assessment on every call and never does it, right? So as preceptors, we need to make sure that our students, especially in internship, and hopefully before that, are doing taking the history, doing a physical exam, and formulating a treatment plan on their patients. There is an allowable, per accreditation, you can have a small percentage of the pre-hospital contacts be interfacility transfers. We as a program do not include interfacility transfers in that minimum number. We don't have to because the students all see enough 911 patient contacts. The most important thing for the students and the preceptors to understand is while the interfacility transfers won't count in that minimum 50 in order for the students to complete team leads, they do count for all of that other nonsense the students have to see, right? So if a student does an interfacility for a STEMI and the patient had chest pain, it may not count towards a team lead, but it does count as a patient contact for an ACS patient. So even though we're not accomplishing the minimum 50 team leads with those interfacilities, the students are still achieving important graduation requirements. And we typically, as a program, grade that as a priority 3 patient so that the students still get a grade and get credit for that patient in their grade. But because it's not a class 1 or 2, it doesn't count towards their graduation requirements. So the importance of our preceptors. So you guys as preceptors are our eyes and ears in the pre-hospital environment, okay? So we can set standards in the classroom. We can teach as best as we can. We can make sure the students are effectively managing simulated patients in the lab, but we have no idea if a student's going to be able to translate theory into practice in the pre-hospital setting until they go into the field, treat a patient, and a preceptor evaluates them. Okay, so the one thing that you have to remember as preceptors is really you are the standard, right? Students as students will mimic the actions of the preceptors. So in addition to being an evaluator, you're also a leader, a mentor. You help the students understand the importance of protocols and applying maintaining standards. And Professor Brian is going to touch on this later, but you as preceptors are probably the most important tool in recruiting and retraining employees, okay? The students don't really interact with your bosses much. The students don't really interact with the facility you work for much beyond the nurses maybe in the ER. Who they do interact with is you on an everyday basis. So if you seem like you like where you work and seem like that you enjoy being there and are nice to the students, they're gonna come work there. If you seem like you hate where you work, they're going to want to go work somewhere else, right? So you want to try to remember that if you want to recruit high quality students to your facility, you're probably the most single factor that plays into that role. What I consider a failure of the program is not necessarily a student that is unprepared to function as a paramedic making it to internship. What is a failure is a student who's unprepared to function as a paramedic making it out of internship, okay? So what we need to make sure of is that when the students are in internship, they're being graded fairly but accurately. And if a student just totally demolishes and does horribly on a call, their grade reflects that, okay? The time for where you're just learning, this is new, you've never really taken care of a patient before, that kind of ends by the time they hit internship. And unless it's some weird thing that you've never seen before and you had no idea what was going on, we have a reasonable expectation the student should be able to manage that. So we want to make sure that they're being evaluated effectively. And if you want to kind of see how our preceptors impact our program, I ran a report this morning before the presentation started. And in just the past 12 months, our preceptors have entered grades for 2,336 calls. So our paramedic students, just in the pre-hospital setting, have treated or participated in the care of over 2,000 patients, okay? So that kind of speaks to how busy you guys actually are, and also the breadth of the learning that our students have, because remember, we're not a program that has 90 students, right? We end up with 14 to 15 students in a class. So that's a lot of patient contacts over the course of 12 months that you guys have had students on. So for expectations, so to function as a team leader, our students need to direct the call. They don't need to necessarily perform every action on the call. We want them to delegate, keeping everybody busy, and multitasking. One of my big mantras is extreme ownership. If you guys haven't read the book, I recommend that you do. It's an excellent book. We have signs hanging all over our labs and our classrooms telling the students to take extreme ownership in their education. And extreme ownership is a simple concept in which you are personally responsible for not just the tasks you directly control, but for all those that affect whether or not your mission is going to be successful. So here's an example. Jason's on a call with a student and says the student didn't perform a primary assessment, right? The student comes back with, well, I did perform the primary assessment, but you turned around or weren't in the room when I did it. That's still the student's fault. Right? If you know as a student your preceptor wasn't present when you did something, under the concept of extreme ownership, you are responsible for telling Jason when he comes back in, hey bud, I did a primary, pulse was good, respirations are good, airway seems to be patent, right? You can't not let your preceptor know that you did something and then later on after the call claim that you did it. Because just like anything else, if nobody saw it, it didn't happen, right? So we want our students to really understand that preceptors aren't perfect, clinical directors aren't perfect, instructors aren't perfect. If you know you did something and you don't think somebody saw it, you need to fill them in, okay? If you say something and your preceptor didn't hear it, you can't wait till the call's over and say, oh yeah, I said that I was gonna give cardizem, but you didn't hear me or didn't say anything, so I assumed I wasn't supposed to. You need to make sure that your preceptors are fully aware of everything you're thinking and everything that you're doing. That is true extreme ownership. So what we tell the students is they need to make sure that their day starts off right and they have appropriate interactions with their preceptors. To me, one of the most important parts of the day is the beginning of shift, or this concept of the morning conversation. So as a student, what do you expect of me? What do I expect of you? Hey, I'm working with Crystal tonight, and I've been having a hard time interpreting lung sounds. So my goal for the next 12 hours is to listen to lung sounds. I'm going to tell you what I hear, and you tell me if I'm doing well or not, right? So then we develop an action plan that we know what I need to work on and what my goals are for the next 12 hours. How's the day going to run, right? As a student, do you have a specific way that you like calls to flow? More importantly, as a preceptor, do you have specific ways that you want calls to flow, okay? Participate in the truck check. The truck check is a great way to test students on their farm knowledge because you're pulling drugs out of the bag anyway. Have conversations about charting, right? Or an internship. Are you doing an EMS chart? If you're brand new to EMS charts, I'm going to hold you accountable for the content of the chart, for example, what you put in there. But your first or second chart, I'm not going to take points off because you didn't check the right box. You never used the darn thing before, right? Everything being documented in FISDAP. Are you going to email me the FISDAP chart? Am I going to log into FISDAP and check them myself? Kind of have conversations about all these things. This is especially important for those students that you've never really seen before or haven't seen in a long time, just to make sure that the day starts off with everybody on the same page. So just a couple of program updates. We got some new items. We put in a request for some new simulators for next year and ended up getting approval to do them this year. So we got some hyper-realistic simulators from LifeCast Body Sim. They really look and feel like real people, okay? The toddler and the infants are among my favorite because both the toddler and infant, if you hand the toddler and infant to somebody, the body flops just like an unconscious or dead child or infant would, right? So if you walk into a room and you say, hey, what's going on? And in this scenario, it's my baby's not breathing, and you hand it over to the student, it really looks and feels like a dead baby, okay? The airways are hyper-realistic. It really looks and functions just like you're intubating a real person. They're all about grade 2 airways. So unlike most of our Fred the Heads, they're actually somewhat difficult intubations. So it's not just I can intubate this mannequin without a laryngoscope type thing. They work really well for video laryngoscopy as well. We also implemented a cadaver lab rotation last year. We took the students down to Hershey Medical Center. We do have a cadaver lab here on campus with the PA program. The difficulty is they have embalmed cadavers. And we need unembalmed cadavers, okay? We won't necessarily pay you, but if a couple of preceptors, when we do the cadaver lab, want to come down and help teach and experience the cadaver lab, we are able to take a small handful of people down every year for that, okay? We were very lucky in that the relationship the college has with Penn State, in that we basically paid for the cadaver. They didn't charge us any lab fees. And most importantly, in this past year, they have a PhD in anatomy, human anatomy program. They had several organs as well as dissected cadavers, and they had several of their PhD students there, so that when the students weren't actively participating in cadaver lab rotations with the physicians, they were learning more about human anatomy from these folks that are experts in it. So we were there for about 4 hours, and it was an absolutely amazing day. And you can see Mark Blanchard down in the bottom right picture. He's using one of our video laryngoscopes. So one of the other things that we purchased was 2 video laryngoscopes. They are Co-Pilots is the brand name. They basically function just like a glide scope. So for those of you services that use a McGrath Mac, just kind of be mindful when you have students that while the students are trained in the art of video laryngoscopy, they don't necessarily use a McGrath a lot, and it is slightly different. So just that's a good thing to pull out and practice with the students, especially if they haven't seen it before. For the services that use glide scopes, the students should be able to use those without much of a problem because they train with a device that functions just like a glide scope, including using rigid stylets. So some important dates if you guys want to come. We're having a graduation, an awards and coining ceremony on August 1st. It's going to be here on campus starting at 5 p.m. We're going to have it in the ACC auditorium, which is the auditorium in the 3rd floor of the same building that the labs are in. And then after that ceremony, we're going to go downstairs into the lab so the students can kind of show their family and friends where they suffered for the past year and have some light refreshments. So every student's going to get a graduation, a coin, and the 3 program awards. We're going to give the plaques out that night as well. But it's going to be right towards the end of internship. It's going to be a nice celebration of the student's success. And we're going to invite every preceptor that was involved in the students' care to the students' education to come. The picture on the top right is the program coin that we had established starting this year. The front of the coin is actually the new program patch. So the college rebranded, and it was an excellent time for us to update our patch that hasn't been updated since 2000. The student's program patch will say paramedic student instead of program on it. There's a couple of things that kind of harken back to history on this. We use the EMS Training Institute specifically because when it was the hospital program, it was called the Paramedic Training Institute. And you can't really see it really well on this picture, but just above Paramedic Program, it actually says established 1979, harkening back to the fact that it's our 40th anniversary this year. All of the current graduates starting this year forward will get a coin. Probably sometime in the fall, we're going to announce that we're going to have the ability for previous graduates to order a coin if you want one. So that information will be forthcoming. But they came out super nice. They're 3D coins. We're really happy with them. And this is just like a small gift from the program to the students as graduates. We're asking folks to RSVP to Bridget by July 19th. It's not a super big deal if you don't, but we just want to get an idea of, because we're going to have some light refreshments to make sure we have enough food for the folks that are coming. The students are going to take their psychomotor exam on August 8th. So for those of you that had previously been involved in registry testing, you can plan on that day being the 8th is when the students are going to take their registry exam. They're going to graduate on August 10th, and then they're going to take their written exam here on August 13th. So if all goes well, all 14 in-program students will become paramedics on the 13th of August. Okay. So it's exciting times. Any questions? I thought that was funny. Okay. So we'll take just a brief break. You guys can get up, go to the bathroom, grab some drinks, and then we're going to get set up for Professor Breon's session here next.